And the next is the cystosomiasis. These are trematodes which induce a fibrotic reaction from the hepatic parenchyma, which causes narrowing of the portal vein. And this has got a typical appearance on MR of the liver, MRI. So here what we see is the T2 liver, the fibrotic strands. This is called as a tortoise shell appearance. What we see here, the white thing, the hyperintense signals are all the portal tracts and the periportal fibrosis, which gives a tortoise shell appearance. And coming on to the next commonest thing will be the cirrhosis. Cirrhosis will be, like we all know, most of the imaging features. It will be a nodular, heterogeneous liver, and the presence of ascites, and the spleen will be enlarged, and the portal vein being dilated with all these parameters: slow flow, reverse flow, thrombus, and the increased resistive indices of all the hepatic artery, of the hepatic artery, splenic, and the renal arteries. So, what we look for in cirrhosis is that we look for the surface nodularity and the heterogeneous. Heterogeneous, most of us are familiar with, we say words, say heterogeneous or a course and echo pattern. One we need to look for is the surface nodularity. The presence of ascites helps us in picking up nodularity very easily. When there is no ascites, then the problem arises. So when there is no ascites and you're still suspecting cirrhosis and you want to look for nodularity, use a high frequency probe. So that will help you out in looking at the looking for the surface nodularity. And the other thing is, in cirrhosis, commonly what you see is atrophy of the segments, and there will be a caudate lobe hypertrophy. And in caudate lobe hypertrophy, you need to look for the caudate veins. These veins, anything above 3 mm is dilated. Here we see the 7 mm one in the initial phases, and the next you see some grossly dilated caudate veins. And the other important thing what we need to do is, while we are evaluating cirrhosis, is to look for portosystemic collaterals. There are umpteen number of portosystemic collaterals which have been described, but there are few which can be picked up by ultrasound and few which are really important to see. One is the gastrosplenic or the short gastric varices here, then the left gastric, periumbilical, then all the splenorenal and the mesenteric, and so on and so forth.